And we'll talk through that here in just a second, but that way I don't forget. And we got a few more coming in, so just one more minute. Okay, so with that, it looks like almost everybody has connected to audio. So I think we can go ahead and get started. And if somebody else joins in, they will join as they are ready, and we'll keep going from there. So good afternoon, everybody. Happy Tuesday. Thank you for joining us for our withdrawal management focus work group. Today it is 2 days before Thanksgiving, which is not ideal timing for getting everybody into this virtual space. So we really appreciate you taking the time to get here. My name is Mariana Sears. My pronouns are she, her, and I am with the Behavioral Health Administration. And I will be kind of emceeing and walking through most of the presentation for today. I am joined by a couple colleagues from the Behavioral Health Administration, as well as Healthcare Policy and Finance, who some will be joining a little bit late, and some unfortunately weren't able to make it today because we cut it so close to the holiday. So we're going to be a little bit of a skeleton crew today on the state side. So with that said, hopefully you all received an email or updated information in the invitation just right before this call, letting you know what the agenda was going to be today, as some of it might be repetitive from what was discussed last month. And we wanted to give you a heads up of that in case that was not a good use of your time at the beginning, and then you wanted to join for some of the new discussion that we'll have here in a few minutes. Let me go ahead and get started. So here's our agenda for today. We're going to do a little bit of level setting where we are at with this withdrawal management work group and just the state's transition to the fourth edition of the ASAM criteria. As previously mentioned just a second ago, this might be a little repetitive for a number of folks who were able to attend last month. And we'll talk through why we're doing that. We're going to talk through some of the transition options that we had looked at a little bit last month, and then recap what we heard from the group last month, and what we're hoping to take forward from that, and what efforts are in place, and what we'll do moving forward. There should be plenty of time for open discussion and some new discussion that we weren't able to get into last month, as well as focusing in on next steps and wrapping this up with the survey and information gathering that we did preview last month as well. So let me go ahead. I'm going to launch a little poll here. And we did this last month as well, but I'm hoping we had just sent out, hopefully that worked. My screen, I'm not super, yeah, I see Mel, thank you. So just take a minute while we're walking through some of these logistics to please let us know who's here, what your connection is to residential withdrawal management services, and whether or not this is your first time engaging in one of these discussions. So today, this is, again, time limited, part of a larger stakeholder process that BHA and Healthcare Policy and Finance will be engaging in around the fourth edition of the ASAM criteria and Colorado's transition over to this larger national standard. This is a little bit different today, and we are recording it, which is not something that we typically want to do during these events, because we want to have an open discussion and have everybody feel comfortable with that without concern about being recorded or where that might go. The reason that we're recording it today was a couple of reasons. One, it is on a holiday week, and we heard from a number of people that they really wanted to be here and they can't because they're already on vacation. However, we really didn't want to cancel the event, even though it was that close to a holiday. So our thought was to kind of just meet in the middle there, and we'll do the best that we can, but make it available for others in case they want to catch up next month when the holiday is over, and just be on the same kind of playing field with this discussion. The second part is we started this discussion last month with an opt-in group of individuals who are interested in looking at withdrawal management in the fourth edition of ASAM. And in that discussion, really recognize that we really do need to target all residential withdrawal management providers to make sure that they're part of this initial discussion and we're on the same page there. And so the thought with recording today and going back and reviewing together some of the information we started last month is those providers, even if they couldn't make it today, they will be able to catch up. And this time next month, all of the individuals who have opted into this, as well as the ones that we have reached out to through ladders last week, will have access to the same information and be able to move forward together. So I will just ask, as folks come off mute and engage in this discussion, if you can, please take a moment to introduce yourself, your agency and your perspective that you're representing while you are sharing. I also might lean a little bit into Mel and some of my other colleagues that are here to help monitor the chat if things come up, to make sure that we're monitoring and responding to both. And again, the purpose for today is really going to be focusing on foundational changes on the horizon around the 4th edition of ASAM. The most imminent provider type that we are looking at is that residential withdrawal management provider. Most impacted is going to be that 3.2 withdrawal management, really focusing in on some of the transition needs that might come from that, and then the ripple effect for communities wanting to start that conversation and continue it as much as we possibly can. All right, so I am going to highlight, as we did last month, but also for the purpose of this recording and people catching up, there will be links in the slides that you will have access to, that when you click on them will go to, like this one goes to asam.org and has a ton of resources that are really helpful depending on where you're coming into engaging in this conversation around the transition to the 4th edition. There's a bunch of implementation tools that are there. Visual aids, different things that can be really helpful to get you started, or if you're already beyond that and you have a really good base foundational knowledge, you can also gain access to the 4th edition of the ASAM criteria and really dive into reading that and then being prepared for some of those discussions that we will be having over these next few months. I'm going to pause for a quick second. I'm going to hit share results, and let's see here. We had about 76% participation in our survey. And just getting an idea of who is in the room, looks like we have 56% provider of residential withdrawal management services, which are directly impacted. That's great. That's the main group that we were trying to target with this initial discussion. So that's fantastic. And then a nice kind of mix of other services here and state providers. So this is wonderful. Sole representative for the agency, it looks like no, which is great. So we're having multiple ears that are hearing it and bringing the information forward and asking questions, which we love. And 26% yes, 5% I'm not sure. Okay, great. And then just getting kind of a temperature check of this. Is this the first interaction with this work group? It looks like, oh, we have 26% that are yes. We have 61% that are no, and then 13% I don't know. That is an important question for us because part of what we're trying to figure out is, as we move forward, our communication plan for targeting specific types of providers as we move these discussions forward. If any of you are part of that yes group, that this is your first interaction, if you wouldn't mind putting in the chat or direct messaging to Mel or myself what that connection point was and whether or not it was that ladders email that we sent last week. If it was, we want to continue down that path. And if there's some other method that you were learning of this, please let us know so we can continue the things that are working. Okay. So we'll go a little bit into the what and the why. So the American Society of Addiction Medicine Standard, or the ASAM criteria, is the basic foundation for behavioral health services in the state of Colorado. That is what all of our reimbursement mechanisms are based on through CMS. We have some statutory requirements to be aligned with the most current edition of the ASAM criteria. And if this is new information to some individuals, we are in a transition phase for the state of Colorado because this national standard has moved from the 3rd edition of the ASAM criteria into the 4th edition of the ASAM criteria. This is really significant for our state because all of our services up until this point have been based on the 3rd edition of the ASAM criteria, which has been in effect since 2013. So we have a decade worth of services that have really been built around this particular version of the criteria, and we need to figure out how to work into alignment with an updated version. And we'll talk about a timeline here in a second. So something worth highlighting here is this is going to be a change over several years. So this is kind of going to be a rolling change with ASAM. What we are aligning to right now is the fourth edition, the adult standards that have been released for the ASAM criteria. And this is meant to be released in multiple volumes. So the first volume that is already released that we are looking to align with right now is for adults. The next one that is going to be released is for adolescents. There will be a version in the future around criminal justice involved standards as well as behavioral addiction standards. And these will be a number, I think 4 to 5 years is projected for all of these to fully be drafted and rolled out. So this is going to be a constant discussion over these next few years, with our first step and hurdle for alignment being the adult standards. So as briefly mentioned, there's a couple statutory and funding involved reasons why we need to align with that updated fourth edition standard. And again, the 11.15 demonstration waiver that our friends at HICPUF would be able to speak to a little bit more in the future if there are questions around that. That is fully needing to be aligned with the fourth edition of ASAM for reimbursement from CMS. And that is linked on here if anybody wants to look at that, as well as the statutory requirements in our Colorado revised statutes. And then for the purpose of looking for some of the other part of the why, right, this is a national best practice. And I know for when the discussions that we've had around what this looks like for Colorado services, because a lot of communities have built really heavily around 3.2 in particular, this can be a challenge to look at lessons that we've learned or things that we have benefited from in Colorado that are being removed from this best practice standard. And that is part of the struggle I think that we have in these discussions together, is figuring out ways that this has worked for a number of communities and individuals in Colorado, and how can we continue meeting the spirit and the intention of services that individuals need without while still remaining in alignment with this best practice standard that has shifted its perspective on this particular standard. So our hope is to lean into this bottom point here, that this is an opportunity to grow together. So I'm going to go ahead and work through this timeline, and I will start at the end. So the standard, we are moving towards a full alignment with this standard effective as of July 1st of 2026. We're going to work our way backwards to show kind of what our end goal is, and then all the steps that need to happen in a timely manner to make that occur. So this means that after July 1st of 2026, all of our funding and our certificates, our endorsements, all of that will need to be fully aligned with the fourth edition of the ASAM criteria. And so that is kind of our absolute last date where we need to have this fully in effect. Not sure why that square is there. Sorry about that. So in order for that to take effect and to work, our goal is to repeat the delayed enforcement period that we were able to do with this updated provider rule as part of this rule promulgation process. That seemed to work well for the majority of providers, and giving a bit of a ramp up period to align with this standard, knowing that it is a significant transition and it allows for more technical support to occur without concerns around significant administrative actions, unless there's concerns around health, safety, and welfare. So we want to repeat that if at all possible. So our goal is to take this into effect January 1st of 2026. Oh, that box is really going to bother me. I'm so sorry. So then in order for that to occur, we need to be prepared to go to the State Board of Human Services with these updated aligned provider rules as of fall of 2025, which is unfortunately feeling a little bit more around the corner every time we have this conversation. So this will be a full rule promulgation process. It has 2 reads at State Board, public comments that will be open and accepted and responded to. So it will have its own standalone rule process. The next date to highlight that's important for all of us to be aware of is the 1 year away mark. July 1st of 2025, BASOs will be open and active. We will be exactly 1 year away from not being able to issue anything that is out of alignment with the fourth edition. So this is really kind of that really important marker between now and then to make sure that our transition is off in good standing and really ready to move forward within that time period. Excuse me. So then this means that our main stakeholdering process will need to occur in spring of 2025, and it will be multiple months long. Our hope is to have multiple options for engagement, virtual, in-person, work groups, and so on. And this is where we're at right now, winter, moving into the spring of 2025. We're taking these months to really get some information now that will feed into our larger stakeholder and rule drafting process, but trying to start by gathering the right folks to the table now, getting this information so that we can pull this information together, have something to react to when we get into these first few months in the spring of 2025 and feel like we are starting the state off on the right foot with this transition. So the main thing that we're going to highlight here today, if you have not had a chance to look at some of the changes that are proposed or part of the, not proposed, that are part of the fourth edition criteria, this is a really helpful chart because you can see here the changes that we are expecting as part of the adult continuum of care. So as you can see, there's a couple levels of care that have this little square around them that are essentially being discussed or going away as standalone levels of care. So we will no longer have that early intervention 0.5. Level 3.3 is one that will truly be embedded and providers are expected to be able to handle individuals with that cognitive impairment at multiple levels of care. There are some transitions on the withdrawal management side where you can see level 1 withdrawal management and 2 withdrawal management, which we added this year with the updated provider rules, will transition over to 0.7s, indicating they have a medical component to them. And we're going to see some exciting things, which we'll get into in the spring, but knowing that there are some pros that have come along with this transition as well. Long-term remission monitoring is going to become our level 1.0, which is really exciting to incorporate that into our behavioral health services. So, but with that said, our level 1 that we're so used to at this point will transition to a 1.5. So this move will be, there will be a lot more changes than just to 3.2 withdrawal management to highlight here. So as you can see here, the reason that we're zooming in on this one and really wanting to take some time to target and get all of the 3.2 withdrawal management providers to the table is that in the fourth edition of the ASAM criteria, there is not a standalone withdrawal management service. So 3.2 withdrawal management is embedded in a residential level of care. So that means that residential providers that are providing 3.5 services will need to be able to manage withdrawal management needs in-house. And it's intended to be a way to continue, to keep withdrawal management needs in-house, allow individuals to enter into services there, continue a residential stay, and then move out to community. Or if there was a situation where somebody requires withdrawal management while they're already in residential programming, they do not need to be moved out of the facility. They can stay there safely and then continue to move through their services. For our state, where we have so many providers and communities that have really opted into those standalone 3.2 withdrawal management programs, this is extremely challenging to figure out what this will look like in the future because we rely very heavily on that for a lot of purposes. So we will be talking about that here. So I'm going to go ahead and just pull up the three kind of main transition options that hopefully these categorize or at least, kind of lay some foundation for the three main options that we're going to be walking through today. One is, as we just mentioned, in the fourth edition of ASAM, level 3.5 residential will have withdrawal management protocols and can handle this in-house. And it's, again, intended to continue that residential as the main treatment venue and keeping individuals and services while they're there and reducing kind of that revolving door that potentially could happen with some standalone withdrawal management type facilities. There is this level or this second option, which is one that we're going to walk through a little bit more here today. And the survey that was previewed earlier is really gathering some information around this potential option, which is looking at withdrawal management for the state of Colorado as what it has really become for us, which is a crisis-involved service that is provided to different parts of the state. And so in this particular option that we're going to walk through, it conceptualizes more of a receiving center type model in which a provider would be licensed as a walk-in crisis or a WIC facility, a crisis stabilization unit or a CSU, and will have withdrawal management protocols. So they're able to handle whatever type of crisis might walk through the door, whether it is substance involved or psychiatric. They can walk through, screen, and react to that crisis that is coming into this kind of receiving center type model to be able to ensure that we do not reduce access to that emergent treatment need that is presenting across our state. And then the third option, this is potentially serving different levels of care. And this could cover a number of different things, right? There are some facilities where, there might be reasons why moving to an IOP or some other service might fit for a provider. This really should capture any other options that might be there. But for right now, really focusing on those other two that might require a little bit more discussion as far as stakeholdering and are not quite as easy to understand what that transition might look like. I'm going to pause for a quick second. I can't see a ton of faces, and I just want to do a quick check-in to see if I'm going to look at the chats real quick and see if there's any huge thing that I'm missing, or are people doing okay with the pace? Too fast or too slow?
We have not had any questions in the chat yet or any feedback about pace.
Okay. Thank you. And I just figured out my Zoom just flickered again. And so can you all still see the presentation? Because now all yes. I see is Mel. I see your face really big on my screen, and I don't know what I mean, it's a good thing. I don't know how I did that though. Let me know if it gets a little weird, but I'll continue going down this path. So for the majority of you, I know this is going to be a repeat because we looked at this last month, but for those that are new and those that are watching the recording, we have a couple things that we wanted to walk through with this WIC plus CSU with withdrawal management protocol proposal. So really, as mentioned on the last slide, what this will be is a combination of these different types of licensure and or endorsements equipped to handle substance-involved crisis, right? That's what the withdrawal management protocol would ensure is present. But as mentioned, this really is intended to build up the crisis system. It would maintain those access points that potentially could be removed if all of our 3.2 withdrawal management providers say, yes, I'm going to go to 3.5 residential, I'm going to make that work. That's great for a number of communities that will work really well. For some that might not, right? Because this will reduce that kind of in the moment crisis access that they might need and might rely on that 3.2 provider for. And so one of the positive parts of this is it would actually maintain, and if not maintain, it might also build our access points to crisis-involved services. The other possible pro to this is for a number of our withdrawal management facilities, they may not be really physically equipped to transition easily into a residential type setting. Some can, and they'll be able to do that, and that might be a good fit for them. But there are some where having dedicated bedrooms and really kind of very specific requirements that fit into a residential type setting may not align very well with their physical plans. And so we want to learn more about that. This is a successful, the crisis receiving center type model is something that is successful in other areas. So we would like to lean into the parts of that could be successful and see if we can replicate that as part of this transition. And this really could be a realistic option if acted upon promptly. So one of the benefits that we had last month that I'm sad to say we don't have today is we had a decision maker on BHA side that was present and really able to engage in real-time questions and conversations about, well, what about this and what about this? And unfortunately, with the holiday, we weren't able to have that present this month. And so if there are certain questions or information that you want to receive around this, just please know that we still want to hear it, and we'd love for you to put it in the chat or ask it, and we'll keep track of it. Just know that we may not have immediate reactions or responses today because we do need a decision maker present that can make some of those next steps for us.
Mariana?
Yeah.
Really quick, I do have a quick question. Somebody direct messaged me wondering where the recording of this meeting is going to go. And I know that we're doing some changes on our website, so I wasn't quite sure if you know where this is going to be posted.
That is a great question. So I don't think we had a plan of publicly posting it. I think I'm going to say I think the plan that we had, and we are open to discussing that as well if there's a better plan for it, was to share it with providers that would be part of this group, right? So the individuals that we reached out to last week that were directly impacted 3.2 and 3.7s directly through ladders, we would offer them access to the recording as well as those of you that are on this call. But the plan was not necessarily to publicly post this one. It would just be offered to individuals and to providers that are directly impacted and
Great.
part of this
Thank you.
discussion. Sure. Thank you. Thank you. Ooh. And then kind of going back then to, not having leadership present for today's particular session. This is absolutely something that leadership on BHA and HICPUF side, and also some of the BOSSOs have had discussions around whether or not this would be a realistic option for the state and something that we could move towards. And there's a lot of impetus behind this that this really could work. And so what we're asking for today and coming to you and presenting this and asking for some information to gather back from you in the survey is really intended to, in this, it very early on in the new year, to look at this information and to see what our options may or may not be. So it is very much supported by the state on both sides. And again, so we do intend to engage in more targeted discussions around this. So this one in particular, like we said, is meant to pull in the residential withdrawal management involved providers. We do have a discussion that is set for December, in which we're hoping to pull in some more crisis stabilization units and WICs as part of that discussion. But certainly this group is still part of that as well. But we'll just we just need to kind of keep the target moving around to make sure we get everybody present and in these conversations sooner rather than later. And again, part of this, we are looking at a pretty quick turnaround as far as needing to make action on some of these items that we move forward. There are some changes with this just in our own statute that we would need to look at, right? the ECIC involved requirements very much live with 3.2 withdrawal managements in statute. And so there will need to be some statutory changes no matter what for our state in order to support this transition to the fourth edition. And so that's part of what's informing this movement going forward as well. So I want to highlight on this particular slide, there is this document that is hyperlinked. That again was started as a supplement to the October 22nd work group. And really it's intended to provide some information going forward about here is what, here's a starting point for a comparison. If your agency is really familiar with 3.2 withdrawal management involved requirements, but has never really looked at WIC or CSU, here's an opportunity to take a starter reference and really look through, okay, what might be relevant for my particular agency. Here's what my setting looks like for a 3.2. Here's what it would look like if I need to add in the WIC and CSU. So this is the starter that we shared last month, and there has not been a ton of, there hasn't been updates to this particular document yet. We did receive some positive feedback as far as a table like this is helpful, and we might want to build some of this out a little bit more in order to better understand what this transition might look like. But yeah, so for the purpose of this and just getting the recording going, making sure that people know how to utilize this tool, that's what this is intended to be. Take a moment to, if you have not done so already, look at these requirements that were pulled out of current rule, see what would fit and what wouldn't fit for that transition if you were to move your agency over into this kind of combined crisis type service model. And I'm seeing we have some chats here.
We'll go back up here to Trisha's first question. Trisha was wondering if you can share in what other areas has this model been successful of a combined WIC-CSU or receiving center model?
This is one where I would lean into Mark Condajani because he is the proponent of really where this crisis model has succeeded. And I'm not sure I'm going to be able to recall it straight offhand. I know he's mentioned several other states where this has been done. And I believe he's also highlighted a couple of internal providers in Colorado that have something like this. And I'm just not sure I might be able to come up with them off the top of my head.
So I can jump in here. So this receiving center model, we do have two locations within the state that already have something like that that they are running, and that is the Longview campus through Summit Stone Health Partners and the RAC through Solvista. And if I am flubbing those names, if those providers are on, I'm so sorry. But there we do have those two places that already are doing this model of service that they're providing to the communities.
Okay. So thank you for the question, Tricia. And I'm sorry I don't have this. This is another one where, yeah, we kind of lean heavily into other expertise within BHA, and without having everybody present, I just could not recall the other states and examples that were given. I will say if there is anybody from the crisis team who's on the call, and I can't see who's all here, that knows and wants to jump in, please feel free. Otherwise, we can get that information and provide that out as well in case folks want to look at those models too. Karen, I am seeing that, oh, sorry, if you just heard that, my phone just beeped. Will the link be available on BHA website? It is not opening right now. And can we put locations in the chat? So Mel, would you be able to put your locations in the chat? And Karen, coming back to your question, I don't know for sure if it's going to end up on the website, but I will talk a little bit about our website presence here in a little bit. But I will go ahead and check the permissions when I'm done to make sure anybody with the link should be able to open what I have. But I can also attach it as an email, as a PDF, and then that way you don't have to worry about permissions at all. That's what we did on some of the other communications, and unfortunately, if we get into a discussion point at some point as well, I might be able to pop a PDF into the chat. I just don't know that I can multitask well enough to do that while I'm talking. So thank you for that. Okay, perfect. So then I'm going to go ahead and keep going, and quick thumbs up if you can see. I'm hoping it didn't change the screen. It should be. Thank you, Sarah. Okay. So then this slide really just leans into what I think is probably the most helpful way to look at aligned residential in the fourth edition. And so if you click on this, and this is not something that is on BHA's website, this is actually borrowed off of ASAM's website in one of their implementation tools. And same thing, I will pop that in the chat as a PDF once I have a chance to focus on doing that. But this is a good kind of high level comparison of what you would expect to see at a 1.0, a 1.5, 2, 1, and 2.5, and then moving into residential services and what these expectations are in the fourth edition of ASAM. And so no matter what, our 3.5s will look a little different than they do current state as far as the expectations of having a medical director that is part of this process, right? They're intended to incorporate these withdrawal management involved protocols in their residential service, which is it's different than how it's been conceptualized or staffed up until this point. So even if a withdrawal management provider chooses to move over to a 3.5, it's just not going to be the exact same 3.5 as it is conceptualized and operated today. Some other things that you will see, and these are part of what we're really going to work through going into these next few months as well, is there's an increase in alignment with service hours. And I know I can already feel as we're talking about this, right, the stressors that are coming along with this around personnel and the staffing issues, and there's a number of different concerns that this brings up. And that's why we want to highlight this now and really keep coming back to it to see what we can come up with together to make this work for our state. So I'm going to make sure that people have access to that. And so that would be the comparison for if your provider type decides to transition over to a 3.5. And then going into the survey. So we have this link, and we'll be able to share this as well. So really, this survey follows a similar line of questioning that was brought up in October, and that the questions are listed here, where essentially this is trying to understand a little bit more information about what would this implementation look like, right? What does your agency already have a transition plan in place? Has your agency already looked at this and decided we're going to be a 3.5? This fits for us. Is your agency in the very beginning stage where you really haven't looked at this yet and need some time to really look at this? Is this the first time that you're hearing about this idea of the receiving center type model and want to take some time to look at it and see what that would look like? These are the questions that leadership has asked to gather information about so that we can get this information from all of the impacted providers across the state, have an idea of what this financial impact might look like, what impact to services might look like, right? If we have a good temperature check of certain areas of the state that might be leaning one way versus the other, right? That helps inform potential service gaps in different communities that might be impacted differently. And so these questions hopefully will be a little bit familiar for folks that were here last month and new for folks that are just joining now or watching the recording. But please take some time to look through this, and really, if you can, take a moment to give us this information so that we can gather it, really look at it in December and make action on this information going into 2025. So some of the questions, right? Would you require construction? Would you need to close completely? What would your operating costs change look like if you were to do this combined WIC CSU withdrawal management type facility, given the increased staffing requirements? And again, that goes back as kind of that initial reference point to look at. Please look at that table that will be connected to this PowerPoint as well. And then just to show you, we do have it set up where there are the email is required. And part of that is the way that this is set up is once you input all of your information, it will send your responses back to you. And the hope with this is that way, as you move into this, it does say, are you submitting information on behalf of the whole agency, right? And then we can make sure we don't have duplicate entries and things like that. So please take a moment and look at that. And the comparison table is also linked in there. Okay, so before I go on to that one, I'm seeing a couple questions in the chat. Let's see if we can toggle back. I see Stacy, will all levels of care 3.1, 3.5, 3.7 now be required to have withdrawal management protocols with the removal of 3.2? So, Stacy, I am going to phone a friend and look at a resource because I do not have all of this memorized just yet. So give me just 1 second. I can't speak for 3.1. That's the one that I would need to double check. But yes, to 3.5 and 3.7, those would need to have a base level of withdrawal management protocol that is part of their process. The 3.1 is giving me a little bit of pause because I don't know that I've looked at that one specifically.
And just to hop in, anything under the new levels of care that has a 0.5 or a 0.7, the expectation is that they will be able to assist with withdrawal management. So particularly those 3.7s, that is the level of care that the withdrawal management is rolling right into, as you can see from this chart here. So anything that's a 0.7 must have withdrawal management protocol. 3.5 has to have withdrawal management protocol. 2.5 is expected to as well because it's partial hospitalization. The 0.1s, again, we're going to double check. I don't believe, but we'll go back and look again at our resources. But the understanding is that any type of service that you have resources that you can provide and those referrals into somewhere for all of your clients that they can receive those withdrawal management services if you don't provide them at your location through your agency.
Beautiful. Thank you for that, Mel. And I'm seeing a couple other chats here. Janelle, can you share the requirements for the facility for WIC and CSU? So we can definitely go back. Let's see here. Boop. I think the starting point. So really, when we're looking at this is a starting point for this discussion, right? We do not have proposed updated standards to react to yet. This is kind of that initial part of the discussion where we're saying this is what is in current state, and if we were to look at this, what things would work, what things would not, what things would really move the state forward in a way that is going to work, that is going to continue to be reimbursable and to be a sustainable model that will continue, if not to increase, access to care. And so what I would say, going back to Janelle's question, I think looking at this comparison table and looking at these current standards is probably going to be the best thing to answer your question right now, knowing that this is part of that discussion, right, going forward of if we are truly looking at making this combined model, we would be looking at this together to see what makes sense as part of this process and what does not, and who do we need to bring to the table to make sure that they're aligned and things like that. So I would definitely encourage looking at this table for those current standards as that starting point, knowing that we don't have that drafted language going forward of exactly what we're asking for yet. We're in that initial information gathering and discussion phase. And then Kevin, going to the language that's been used so far of directly impacted. And yes, you're absolutely right. This is a very significant change for a number of providers. And right now, 3.2 is the one that is most present in front of us, and the ones that we're trying to at least get agencies that are very much connected to 3.2s into the fold to make sure that we know that they're aware of it. Absolutely, 3.5s, all of the other providers are going to be impacted by this as well. And that's when we're saying there's going to be different parts and times where we have to look at targeted groups that we can try to pull in, because this gets very unwieldy very quickly. And so it's really challenging to try to pull all of the different strings together and crochet something that really makes sense at the very beginning. But you're absolutely right. There are going to be other programs and other provider types that are very much impacted. This is the starting point of really looking at 3.2s and that residential withdrawal management component, but absolutely other residential programs and other provider types will be brought in as well. So I wonder, I'm seeing the chats starting to explode a little bit here. What I would like to do is if we can take a second and go through what we heard in October real quick, and then I think that will open the door for a little bit more discussion and pivoting back over to some of these chats, as well as making sure that we do a time check and kind of know where we're going. So just to kind of recap where we were in October, right? We have a lot of things that we need for sure. We need information, we need personnel, we need funding, we need creativity, we need intentionality. There's a lot of things that we need that we don't have at this very moment, which is extremely challenging, right? For everybody, for providers, for communities, for those of us that are trying to help kind of move this forward in a way that would be as smooth as possible. So what we want to kind of report back on are things that we have moving forward and what we're hoping to gather to continue this process going forward. So information is needed. We talked last month about really focusing on the impacted providers and the way that we were approaching this so far of opting in and not being able to really post this in a way that was easy to access and to find and things like that was not working. That's how we ended up with doing this more targeted email to 3.2 and 3.7 involved agencies this last week, and intend to continue that kind of targeted impacted providers depending on what the discussion is going to be for each event, right? So residential is going to be most likely one that will be its own kind of little area that we will need to pull together and have that discussion. And the 3.2s will most likely be involved in that because they have the option of transitioning to residentials as well, so that they will be looped into that too. We also heard loud and clear that the community education really needs to come from BHA. It cannot be the providers that are going to their law enforcement and to their hospitals and saying, here, we can't do this anymore, and here's what's happening, right? That's not okay. So 100%, we heard that, and we are working on multiple options as a starting point to be that source of education. And we'll look at those here in a second. Heard loud and clear personnel, right? Qualified personnel, really figuring out a way to make this work. In particular, last month, we heard loud and clear rural areas. This is a huge struggle, and having to be creative and really looking at what is sufficient for milieu management in order to sustain these types of programs. So definitely hearing that as well. Funding. And this is where I think it was so great to have Mark last month to be able to, speak a little bit more to things that he's more connected to, right? Being on leadership and knowing a little bit more of what the state faces at this moment. What I will say for this particular one is the ask and what we will be asking for in the survey with gathering this information for this proposed receiving center type model is being requested by leadership because this is looked at as really a potentially helpful, sustainable model for the state and what we want to see, what that would look like for providers across the state, so that we know going into the 2025 calendar year, what are our options for trying to help with that funding, since we know that that is the ask of the state to move this forward. And then really creativity and intentionality, right? We are hearing what are the opportunities, why and why not. And that's why going back to that question of what will the requirements be of that WIC PLET/CSU, we don't know for sure, right? We can tell you what they are right now, and we can look at what right, what makes sense within there, but we do not have drafted rules for that just yet. And this is our opportunity to look at what could be sustainable and what could not, right? So viewing it as an opportunity and being able to say the why or the why not to these ideas that are coming up. And then the other part was really, identifying and filling the obvious and not so obvious purpose that these transition and these providers serving communities. 3.2 is the most obvious one that is right there, where we know it serves a ton of different purposes for different communities, and it will leave pretty big gaps if it just disappears. And so we are really trying to look at what can we put in that place that serves that purpose, that really fills those obvious the obvious service and purpose that it serves, but as well as really working with you all to identify the not so obvious ones and make sure that we're not missing those gaps as part of this process. So just going into that community education, we did mention last month, and I know for the purpose of really targeted communications for the community, this is not going to serve our purpose. But again, we're recording this so others are aware as well. We do have on the website, on the laws and rules page, there is a more general one pager that is helpful, that brings a little bit more information about what does this transition timeline look like. Talks through the different volumes. It talks about the why, the when, some of the notable level of care changes that will be present here. And going back into this, we are working on more targeted communications that will speak to law enforcement, that would speak to hospitals, that would speak to other parts of the community and really grab attention in a way that brings all of those community partners to the table, as well as brief video or kind of like a brief little snippet and explanation of why this is important and what we need to do, so that it can speak to different types of audiences. We're hoping to have that in December of 2024 by the next time we meet. And then the pull, we have an intention to pull in our regional community engagement managers and team. This has not been set in stone yet. This is a new conversation that we started to have, but that is part of the reason why this part of BHA was developed, was to be able to get in front of this in communities. If for some reason we cannot physically be everywhere at once, we have teams that will live in that area and they're able to help us with that, in addition to getting the rest of us out there as well. So there are more efforts in the works to make sure that education is coming from the state and not going to land solely on the providers. Okay, so I want to pause here for just a moment, if it's okay, to kind of come back to some of the chats that I can see are going, continue to come in as well. As a quick time check, we are at 12:51, and that gets through as far as what we for sure wanted to have on a recording with the kind of repetitive information that we discussed last time. That is kind of the level setting that we wanted to make sure all of our 3.2s and 3.7s who might not be able to attend today would be able to catch up on up until this point. So going forward, if there is anything that you want to share, or any comments, questions, or anything that you have that you don't necessarily want on the recording because it's not part of that education of getting everybody up to the same page, please let us know and we can pause the recording and then resume it. Because again, it's not typical that we would want to record an event like this because we do want to have an open dialogue without concern about being recorded. So please just let us know if that's the case. And then if it's all right, I might look at you, Mel, for a quick second to let me stop talking and catch up on getting some stuff, some PDFs and things in the chat and just kind of catch up with what happened there, if that's okay.
Sure. I think let's go back to so I know we addressed Kevin's comment about 3.5. I see the Stacey's question about withdrawal management protocol requirements be held to the same treatment requirements. As Mariana stated, that's something that we're still trying to determine of what this is going to look like. Janelle asked, can you share the chapters that this refers to? I believe Janelle was referring to the information that was pulled to create the crosswalk and where that information came from.
Great. So yeah, I am seconds away from getting the PDF version of that of the crosswalk, and it does at the top of each column. It will have the chapters that are there. They should be chapter 6 for the 2 crisis involved ones, and then chapter 5 for the withdrawal management 3.2.
And then I have Charles Davis. Is state prepared to shift the funding model from a fee-for-service model to a capacity model with increased costs estimated between 30 and 40% higher than existing costs, with significantly lower utilization than current 3.5 residentials currently in operation? That is a lovely question. I don't know if our friends from HICPUF have joined us yet. I know a few of them were going to hop on at 1 o'clock. So I think let's actually save that question and come back to it once they are on, as that is outside of EHA's, or at least Mariana's and my understanding right now, and I want to give HICPUF a chance to chime in on that. EC added, in terms of milieu management, it is also extremely challenging to get patients not in active withdrawal to understand why those who are in active withdrawal are not required to engage in treatment in the same way. This will put strain on treatment staff and result in higher rates of burnout, resulting in more people leaving the field. That's a fabulous comment, Stacey. I'm really glad that you added that. Those are things that we're definitely going to look at it and consider as we are drafting the rule language. So thank you for adding that. Kimmy asked if we can make sure that the links in the chat translate into the PowerPoint that we send out. And I said yes, and that in the email that we send out with the PowerPoint that we would make a list of the links separate in the email, so that way there's easy access to those links. So sorry, Mariana, I added more duties to your plate there.
It's all good. Thank you.
Crystal stated that she agrees with the pieces here that are incredibly significant in terms of changes to current 3.5 levels of care. Another unfunded mandate is going to be an insurmountable challenge. To hire a medical director when 3.5 is clinically managed, not medical, is cost prohibitive. Yes, I know that was something that when Mariana and I initially were looking at the ACM4 information that they put out, we were both surprised to see that a medical director was required for a 3.5. Unfortunately, that's something that is out of our control, as we have to follow those ACM4 standards. But we were surprised as well. I know that's not an answer that does anything, but that is something that we have also been talking about. And so this is where I think that creativity and intentionality is going to need to come in. Dr. Rob. So Dr. Rob messaged me directly a question specific to if you're serving adults and kiddos, if the sight sound barriers And I replied that yes. And so his response is regarding the crisis, due to requirements for sight and sound separation between adult and child populations in residential treatment, we need increased staffing levels. A basic two staff model is insufficient because each unit requires its own dedicated staff that cannot overlap shared duties. Both populations need independent direct care coverage for all shifts, clinical staff for programming, support staff for meals and activities, overnight monitoring, and medication management supervision. I think there is a lot of gray in the comparison table. Yes, there is. I think there is a lot of gray over the entire thing that we're trying to build here. But that's why we're here. We're wanting to pull in your opinions and pull in your ideas. And so all of this feedback, while we don't have answers now, is truly crucial to what we're working on and what we're building. Charles, some states are continuing with 3.2 withdrawal management along with implementation of, and then I'm going to skip down to your second set here, ASAM4 due to geographical challenges of operating 3.5 residential programs in rural and frontier areas. We have heard of a few states that are continuing to do 3.2 withdrawal management. We have been told that that is not an option for Colorado. And that's something that I'm hoping that our friends from HICPUF, once they join, could maybe give some more information about, because it has to do with funding mechanisms. And then Tom asked, is there a need for so many more CSU beds? That's a great question. When we hear feedback from the communities, there's always a need for more residential beds, and there's always a need for more crisis beds. But I think that's why we're trying to look at this and not just funnel everybody directly into one care model. We're trying to look at how can we best meet the needs of the community, and also what is your agency capable of changing over to if you're a 3.2 WM. It's not going to work if everybody just goes from a 3.2 over to a 3.5. So we need to have these other options. We need to be able to still serve folks with not having to go to emergency departments or to jails because they need to withdraw. And that's the honest truth of it. So we need to be creative. We need to think outside the box and, within the boundaries of what we've been giving from ASAM 4. Mariana, that is the end of our chat there. I will hand it back over to you.
Thank you. So I think I got caught up, at least I got a couple PDFs that I was able to pop into the chat. And as Mel said, the plan with this will be to have all of those either with the links or the direct PDFs as an attachment that can go out to this larger group so that everybody has access to this. I will say I'm going to jump over real quick just to share kind of the build out that we have on the laws and rules page. And hopefully this is sharing correctly still. It used to show on Zoom, it used to have a little green box around the screen that you're sharing, but it doesn't do that anymore. And so now I just don't know what I'm sharing. So please let me know if it's wrong, but it should be laws and rules. And so part of why this was challenging leading up to this is there's a lot of things that are moving, right? That there's been a lot of change, and there will continue to be a lot of change for a period of time. And it's, we're wanting to get this movement going with the ASAM4 involved changes, knowing that we're starting these conversations and having these conversations when there are other conversations that have been happening for several months around updated provider rules and getting some technical cleanup done there. Hopefully a number of you have engaged around the controlled substance licensing updates. And Ryan and his team across the state have been really working into getting controlled substance licensing moved over into the chapter structure so that our rule volume will be easier to follow going forward. There's also been movement around commissioner rules and administrative rules. So it's been a lot. And so it's trying to figure out how to keep this conversation going without overstepping or confusing and muddying the waters with all the other things that are happening right now. So we've had a minimal presence so far on the website because of that, because we wanted to, invite people in who are interested in being part of the conversation. And that's what we started with. And now we're at the point where, with the discussions that we're having, we're needing to strategically invite more people along. And so as you'll see on this laws and rules page, when you scroll down a little bit, our presence is starting to be built up a little bit more around this ASAM transition, and this will continue to happen over the next few months. This is where you will find the more general transition flyer that we have put together. Whoops, sorry about that. As well as our anticipated transition timeline. So if you want to keep a quick copy of this, just to make sure that we know where we're going and what we're proposing and why, that's there, as well as we'll continue to build out these virtual feedback meetings. So we have 2 more that are listed right now, but by no means are those going to be the only 2. There's going to be plenty of other opportunities here. And really, the hope is going to be that we continue this conversation December into January with these more kind of targeted discussions, getting an idea of some of these concerns, gathering this information from you all of like Charlie. I don't know if you go by Charles or Charlie. I'm sorry. I'll just call you both, I guess, for now until I know otherwise. But that information that you're giving, right? The questions that you're asking about 30 to 40% cost increase and things like that. All of that information that we're gathering right now as part of this survey is intended to be, here's the information that we have. We can really look at it, see how that is put together across the state and what providers might be considering transitioning to. And that helps inform the discussions on the state level with funding between HCPF and BHA in the early 2025. So I don't know and cannot speak to what any of that stuff would look like. That's where we really lean into leadership to help us guide it. But they did ask for gathering that information to help inform that discussion. So I just want to make sure that it's emphasized that we're asking for that information to do something with it, and it's not just information that we're just gathering and intended to gather dust. So please keep that in mind and keep an eye on this website because it will continue to build out as more of these events are updated, and we will. As mentioned, some of them might target certain areas for discussion. So, for example, the December 17th one, we were, as of right now, considering really looping in CSUs and ATUs as part of this initial discussion so that we can gather their perspective as well before the calendar year is out. And so we will try to keep the website updated here as well as the invitations on the Zoom links when that happens. Okay, so then, yeah, so I think that, whoops, those were the 2 things that I wanted to highlight there and make sure everybody had access to the laws and rules page and that link. And again, we'll include that in the email kind of summary that goes back out to everybody. And let's see, where else should we go for today? I see some more chats coming in. Feels like the state is putting a lot of burden on the provider with regard to liability, ethical, legal concerns about assessing and determining a level of care. When someone is in active intoxication or withdrawal, clinicians are not always going to want to put the credentials in the crossfires. They will be the ones clients go after if they want to file grievances, not the state who's requiring all these changes. Thank you for sharing that, Stacy, and I appreciate you sharing that concern. Janelle, I agree. Insurance providers for this level of care have also increased, which will cause more issues. Yeah, I think going back to kind of how Mel was able to more fluently state this earlier, right? That this is not a straightforward and easy ask that's being made. This transition is not anticipated to be an easier, straightforward one in any sense. So we do appreciate bringing some of these other concerns up to our attention so that we can make sure that they're part of the discussion going forward, and hopefully we can figure out a way to move forward together. I do see it looks like a couple of our HCPA friends have joined. So let's see, we have about 24 minutes left technically on the invitation, so we can continue with oh, and sorry, just real quick, I saw another chat. We've been having huge insurance issues for the last year with ASAM items. Any work the state can do to help on that front would be great. Yes, again, there's there's so many layers and so many ripple effects to what is happening here and the way that this has been operationalized in different states, depending on their funding mechanisms and kind of how their particular state is set up and connected to this standard. It looks different, and we have heard that there have been concerns with insurance within the state of Colorado expecting alignment potentially with the fourth edition of ASAM sooner than that, when we're not aligned with that, and that's not something that we should do. So that is definitely on the radar as well. Something that is part of this consideration and this movement in the next few months going forward. With that, I wonder, I do see it looks like, thank you, Kimmy, for some more of the information. Commercial insurance have been requiring ASIM 4 since late spring. Okay. Lots of work to be done. That's what I'm seeing for sure. So I think then maybe going back and giving our friends at HCPF a moment to breathe. I know everybody's kind of hopping from meeting to meeting and just kind of getting logged in here. So there were questions around the state and our preparation for shifting the funding model from a fee-for-service model to a capacity model with increased cost estimated between 30 to 40% higher than existing costs with lower utilization than current 3.5 residentials in operation. So I think before kind of handing over to HCPF to see if we can have some of that discussion, what I will also emphasize is this survey that we're asking you to fill out is a great place to put some of that information so that we can gather it from all the different providers. And if you're looking at your costs, Charlie for Crossroads and really saying, this is what we're anticipating this would really look like for our agency and we serve these regions in the state, right? And this is what the impact is going to be. This is a good opportunity to put that there. Can we guarantee that we'll be able to support everything in it? Of course not, but you're giving us this information. We can gather it and really compare it and understand what the trends and concerns are across the state. And that helps to inform some of the fee for service and the capacity reimbursement models that you're asking about. So please make sure you do take some time to fill this out as thoroughly as you can, because that information will be taken forward. And I don't mean to put HCPF necessarily on the spot, but so we were looking forward to you all being able to join with some questions that had come up specifically around what our funding shifts might look like. And since that's not necessarily our expertise on BHA side to present, we wanted to hold some of those questions for when we had our friends from HCPF here to field some of those questions. So is it okay if we open the floor to some more kind of funding involved questions or information to gather?
Happy to take notes. Sorry that Amy and myself needed to join late today. Hopefully, we will not have that same type of urgent conflict come up in subsequent meetings, but happy to listen to questions and take notes. I would just preface any discussion around funding as we are not going to have definitive answers on what that's going to look like today, but very happy to start collecting where your heads are. So what have you got?
You're right on track with that. That was the preface at the beginning as well, is we may not have all the information and details today, but gathering and reporting back. So perfect. You're right on point. Zach, it looks like you had a question. Do you want to come off mute and present that, or do you want us to look at it from the chat?
I don't mind coming off mute.
Thank you.
I was just curious about the funding mechanisms with like some of the IMD classification. Like if I'm a smaller provider and I switch over and I have less than 17 beds, is there still buckets of HCPF funding streams for that, or is it primarily through that 11.15 waiver? I know IMD is like a little bit complicated space in terms of in lieu of and all that kind of jazz. So it's just my question.
Literally none of that has anything whatsoever to do with how the 11.15 works or how reimbursement works. So I would not conflate those two issues. IMD or not, reimbursement is identical. So no matter how small or big you are, it is around the service you provide. IMD is a very technical issue that a box is checked for, and the purpose of us having an 11.15 is that a limitation is waived. So none of it has to do with impact to funding.
Cool.
I'm glad you're here to answer the question, Jen, because I'm not sure that I'm not sure that I even fully understand the 11.15 waiver and IMD and some of those distinctions there. So Zach, I appreciate the question and yeah, and asking it so that we know whether it's connected or not.
Uh,
Go ahead.
In general, our 11.15 waiver, because as I'm looking at folks that are on this call, a lot of folks on this call kind of work with us also more broadly than just specifically in this space. And part of the reason that we need 11.15 waivers is it waives a limitation. And there are limitations for programs that are classified as IMDs about the number of days in a calendar month that can be paid. So it doesn't have to do with like rates of reimbursement. It has to do with whether or not the limitation applies. And in the SUD space, because we have the waiver and we're in year 4 of the waiver, that limitation restriction does not apply to folks with SUD diagnoses. What is pending right now with SMI would allow a similar type waiver in the mental health space. Just being a little nerdy there. See, there's a follow-up of different codes in the 3.5 for withdrawal versus residential. So no, there will not be different codes. Essentially, the way that the work will move forward in collaboration with BHA is for any of you that have already read ASAM4 working with other funders in that space, withdrawal management will be included within codes, not included within level of care. So if that is included within a level of care, then reimbursement would follow the logic that everything that would be included within a level of care would be considered when new rates are set for each of those levels of care. Charlie, does that answer it?
Charlie, I'm not sure. I've heard you referred to as both. I know you all had some questions earlier in the chat. I'm wondering if you want to come off mute and ask those questions to Jennifer, or I'm happy to read them as well.
Yeah, this is Charlie. Yeah, I think for us, Jennifer, what we're trying to figure out is how you mix these two completely separate treatment regiments within the same system, and how would, if the state doesn't know if the person is detoxing versus attending residential treatment, how do you comply with certain things if you don't know that they're incapacitated and can't participate in treatment while they're growing?
Sure. So
without different codes.
Yeah. So sure. Essentially, I would really say our partners at the BHA or who I'm going to look to around the very technical rule part of saying, so as we look at ASAM4, there is a scope of services which includes withdrawal management as part of the scope of service for which a facility that is a residential facility or an outpatient facility is licensed to provide. What ASAM 4 tells us is each of those levels of care requires the inclusion of withdrawal management. And I'm, again, going to be a little nerdy here to say withdrawal management is not detox. It is withdrawal management. And by definition, withdrawal management includes an MAT component, but also treatment. So it is not simply detox, and it never has been simply detox in the last 4 years as we've worked with ASAM. From a Medicaid perspective, reimbursement ties to what our BHA partners set up, that here's a level of care we license, and we go and we say, okay, well, what are all the things that need to be delivered associated with that level of care that is licensed? Here is how Medicaid is valuing paying for that set of services as defined by license type. And I will defer to Mel and Mariana to add about the license piece there.
Yeah, thank you for that, Jen. I think part of it was, we're looking at, yes, the scope of what the services would be provided within that provider type. And I think a number of the questions that are coming up in alignment with that is, what would the reimbursement changes look like, right, to be able to support that level of care. And in particular, we had a little bit of chats earlier around like residential, right, including a medical director, and then having these withdrawal management involve capacity as part of their scope, right, that's significantly more expensive for providers. And I think there's a lot of interest in understanding that a bit more so that we could figure out as all these providers are really looking at what is the best option for their transition, that they're really making that informed decision of which one will be reimbursed in which way, and knowing that we're not going to have all the answers, right? But really understanding what that process might look like to help inform those discussions.
Sure. So the expectation is, since withdrawal management will be required under a license type to be included, you would need to have an organizational structure where you could meet your license requirements to provide that service. And yes, the downstream is, you're absolutely correct. We need to look at what funding looks like to ensure that an organization that provides that level of care to meet license requirement compensation is set up to recognize that those withdrawal management supports will now become part of those residential levels of care across that continuum. That is absolutely correct. So while you might not need to use withdrawal management with every member every day, we obviously are going to have to build codes that account for withdrawal management is something that needs to be supported.
Daisy added to the chat, another worry is Ray's continuing to confuse withdrawal level of care with residential when they are both called 3.5 or 3.7. For example, Ray's will still deny 3.7 residential, claiming the patient has detox and needs to step down, even when the facility is licensed as a 3.7 residential. How will this be prevented in the 3.5? If you are requiring withdrawal management in residentials, we will need a way to differentiate care from the BHA residential treatment requirements, as someone actively withdrawing is not going to necessarily sit through 10 to 20 hours of scheduled treatment interventions per week when they first enter into care.
So I anticipate there are several pieces to that. And when there is not a 3.7 withdrawal management level, because it will be gone, then the only thing that is going to be authorized is 3.5 or 3.7. There isn't a withdrawal management option, so that's going to look different for the Rays. And again, for the last 4 years, detox has not been a thing. Withdrawal management is the thing, and withdrawal management is medically managing the part of detox in MAT plus including services. So Medicaid has not been paying providers for the last 4 years for detox. Medicaid has been paying providers for withdrawal management. And as withdrawal management goes away, Medicaid will need to be paying providers to deliver residential high intensity outpatient or outpatient services inclusive of withdrawal management where indicated. And I'm assuming that BHA, in terms of the rules and the requirements of engagement and services, again, if you read ASAM 4, different rules and requirements, because yes, that will be changing. And now there will need to be considerations that when someone is unable due to their withdrawal management to participate, there will need to be allowances for that. Mel, Anna?
Yeah. Looking at this question, Stacey, I love this because I think this is where those updates to standards and the rules are really going to come into play and that stakeholder process in January and in the spring, right? Where we really look at then how do we write standards in that are going to make sense? Because you're absolutely right, that individual who is entering residential care hitting the ground running, doing 20 hours of scheduled treatment for somebody who is entering in that state of withdrawal is not going to make sense. And so that's where we have that opportunity to update the standard to something that's going to make sense. And then on HCPUF side, they have that the reimbursement that's going to cover all of the stuff that's part of that level of care. So this really could be a good time to look together at that standard with this kind of organic transition point and make things make more sense in our rules as well. So I love the question, and I think that that's going to be a good thing that we'll be able to clean up together with the rules as well.
I would also ask, I love the idea of asking you all to fill out the survey, and I would love feedback as I think about this and what you're laying out there around estimates that you all have as on the ground providers of some of this around the changes to length of stay for 3.5, 3.7, 3.1, because again, when I think about the raise and where the department gives direction to the raise is sort of estimating, okay, if folks are not able to fully engage for a little bit longer because we need to get them through withdrawal management where there is some engagement in treatment, but less than fully expected. Feedback on what you all would see as how much time is that likely to add, and where do we need to set some of those requirements around minimum lengths of stay? And we also, not that I'm setting myself up and giving you guys things to tell me back, but also thinking about the idea that for withdrawal management, we do not require pre-authorization, but for other residential levels of care, we do require pre-authorization. Happy to have your feedback and thoughts on how we might navigate that and what that looks like. These are all really important questions.
So real quick, and then I'll jump over to Zach just because I'm noticing we're short on time here. So I just reshared my screen and hopefully you can see this. I will go ahead and add a couple questions to this existing list based off of what Jennifer just said as soon as we're done. So it'll be just a hair longer, but we'll ask those questions as well. Including just an open text. What aren't we asking? What else do you want us to put in here so that we can gather some more of that information? So just know that if you hop into the survey in the next 20 minutes or so, it may not be there yet, but I will get that added in as soon as we are done. And I am so sorry. I did not mean to cut you off. Zach, you are up.
No, you're good because Jen happened to touch on a topic that's obviously one of our internal items. I mean, I would love to talk more about some of the technicals on that because I feel like in many cases, if we're expecting an influx of withdrawing or intoxicated patients, and just the added burden with that, it makes sense to have that kind of initial days built in. I realize it's different for 3.7 versus 3.2, but using like the initial 5, for example, at 3.2. And then from there, on that quote unquote concurrent auth, then thinking about the minimums from there. And I know minimums are a tricky conversation because once again, if we're talking direct from ASAM, there is no such thing as a minimum stay or like how long things should be. It's all about just continued medical necessity. I do think stakeholdering around those minimum requirements would be helpful, and to make sure that it's coming direct from HCPUF, because even when we made that change from the last go around, some of the rays did not change immediately. And there's still some unanswered questions of, on the initial, can a doctor override the minimums? Because we've experienced that as well, where they say, well, because I benched it with the doc, they can override the 10-day or this minimum, so on and so forth. And rays also get to decide how long prior authorizations stay open, or they get to decide on post-admission, getting something and then getting those initial days. Some try to admin deny. And so I think standardization around that of like, thinking about, if I do an ASAM, how long is that information good for? How can I reassess? Bed dates are usually out for a month and change. What does that mean for, if it's only open for a week, that does mean nothing. And then they admit, and then there's all those other challenges. So personally, I think a lot of that should be just set as a HCPUF standard. I realize rays get to negotiate certain things, but I do think some of those things, just standardizing it across the board, would do a lot to actually reduce variability and provider burden.
Please drop all the comments. Also, try to get all of you to show up to the SUD forums, other place for you all to be dropping comments about feedback and how we're working with rays. All good points, all helpful feedback for us to have. And just super quickly to the point of like, yes, ASAM doesn't give minimum standards. The idea of pre-authorization is not to say that it's a minimum that needs to be used. It's saying up to this amount, we just recognize that as medical necessity dictates, up to this amount, you don't have to keep going back and forth because that creates a lot of administrative burden. So, we're threading the needle with still it's driven by medical necessity, but we don't want you to like have to keep asking every 3 or 4 days. So the idea of saying anything that meets medical necessity up to this amount is reasonable is where we tried to go.
Yeah, and I agree. I do think the minimums are helpful because I'll be honest, if we're talking below a certain amount of days, it's like why we've had people try to authorize 1 day. It's like, what are you even doing at this point versus like the actual what the research shows of how long someone should be engaging at that level, at those levels of care to like get the success. Otherwise, they'll be right back at that level of care 20 days later. So yeah.
All right. And with that, thank you, Zach, for those last comments and Jennifer for the clarifications there. We are officially at time. So just an action step. We're going to update the survey as just mentioned, and we will have an email that was promised earlier that's going to be sent out with the links and PDFs and all the stuff that we talked about. That will most likely be in the next couple of hours to make sure we can gather some of the information and get the survey ready, but it will go to everybody who was part of this call. As well as folks that were invited to this call as part of the 3.2 and the 3.7 transition. So we really appreciate your time and your feedback today. And hopefully we'll see all or most of you over the next few months. Thank you so much.